Hi, my name is Pashtoon. I'm the Director for Colon Cancer Research at Weill Cornell. I also focus on liquid biopsies here at our cancer center. What I wanted to talk and discuss today was about other therapeutic considerations in colorectal cancer in terms of data and papers that have been relevant in the last year or so that are going to be relevant and may already be changing clinical practice. Our email and contact is noted as on the slide. The first topic or the first set of papers that we wanted to focus on, which would set the theme for the remainder of several articles of interest that are changing clinical care, is this whole area of so-called liquid biopsies, or in the clinic right now, this refers to circulating tumor DNA or ctDNA-based testing. At ASCO in 2022, there was a whole session that was dedicated for the first time, focusing just on ctDNA, and as shown here in slide, that was deemed as the dawn of a new era, which in many ways for solid tumors in general, but then colorectal cancer in specific, is something that is already changing practice and how clinical trials are being done. One key publication that we are a part of that we wanted to highlight, specific to colorectal cancer, which has been the poster child when it comes to liquid biopsies or ctDNA. For the rest of the talk, as we talk about liquid biopsies, this is what it's going to refer to. It's this publication in JCO, which highlights all the different applications of liquid biopsies, as opposed to the earlier liquid biopsies that were for stage 4 metastatic cancer patients, or when the cancer was progressing to pick up acquired mechanisms of resistance. This is something that has moved up the journey or the ladder of a patient with cancer to minimal residual disease, molecular residual disease, MRD, a term that we've borrowed from our hematology colleagues, to early screening and detection. And then I'll highlight some of the key trials and some of the key publications that are using some of these assays to corroborate the differences and also how it's being used in clinic. Broadly speaking, it's important for the audience to know that there are different types of liquid biopsies. Even within molecular residual disease or minimal residual disease, there are so-called tumor-informed assays, where a piece of tumor is sent to make a barcode simplistically of the patient's tumor, and you look for the same barcode in blood, as opposed to plasma-only or tumor-uninformed assays. As the term suggests, in the latter, you don't need to send a piece of tissue or tumor. And to increase the sensitivity of these assays, there are other markers in the bucket of epigenomics or methylation that are done to increase the sensitivity of these assays. And these are very relevant for colorectal cancer, which is the theme of the discussion today. Again, some key articles highlighting how this might be of value in the clinic as well as in clinical trials. So, setting the theme on broadly what has been one of the biggest advances in clinical care, as I said, about liquid biopsies and ctDNA. The first publication is with our colleague, Dr. Cohen, which was presented at ESMO. It looked at the outcomes based on ctDNA positivity, and looking at the clinical outcome of the cancer coming back in terms of recurrence-free survival. In this particular real-world analysis of hundreds of patients, they were looking at a tumor-informed assay. And shown here are how patients did if their liquid biopsy was positive versus negative. You'll see a common theme across multiple publications and presentations that we will highlight, that the negative is not 100%, that depending on how much time goes by from the time of the last assay, the recurrence free, there's plateauing off, but 80-90% of these patients still remain cancer free. However, if you're ctDNA positive, and especially if you don't do anything about it, you'll see a consistent theme of the curves meeting the x-axis, where pretty much within a couple of years, you see recurrence of the colorectal cancer, and this is applicable to other cancers too. And you see a broad separation of Kaplan-Meier curves, high hazard ratios. There'll be a consistent theme as noted in this publication. And the field is not yet ready for de-escalation, meaning that if somebody is ctDNA negative, and they need chemotherapy based on pathology and risk features. It's not like we're not going to give them chemo, but it's provocative based on this real world data set that the benefit was minimal in the folks who were ctDNA negative. Again, not something ready for prime time, but it kind of sets the theme for clinical trials. With key takeaways that I had for this was that it does show that it is feasible, something that you can do. Not surprisingly, stage 3 minimal residual disease or MRD rates were like 30% as opposed to 10% for stage 2. This is what we see in general, so it kind of corroborates clinical practice. And one area where I think, at least from my standpoint, and I would say the community is still discussing this, but a lot of experts would agree that if you truly have a low risk stage 2 colorectal cancer patient and you weren't planning on giving chemo, and the results comes back positive, this is not a prognostic or predictive risk factor. This is more so reflects persistence of disease. That person is not cured, so it may help improving outcomes by identifying patients who actually may need chemo despite what the risk factors say. And then finally, it goes without saying, it sets the stage for ongoing clinical trials that are using some of these assays. This data supports the rationale for enrolling in these trials. Again, building upon the same theme, the next topic that, or the next publication is from the group in Japan, from Dr. Kotani and colleagues. This was a landmark publication in Nature Medicine, just published a few months ago. I would say in a well-informed discussion with the patient in the clinic or any talk about ctDNA and colorectal cancer, I pull up this paper all the time to help answer some of the questions that patients and informed caregivers and colleagues may be asking us, which is a great thing. And again, you'll see similar trends and themes. ctDNA positive patients do not do well. Patients whose ctDNA turns negative, they do well. And regardless of how you put them in risk phase and stages, the outcomes are better if you did chemotherapy, if you were ctDNA positive. So it's becoming more of a predictive marker as well. And not surprisingly, and maybe the assays will keep getting better. Maybe there'll be a time where we would forego chemo in somebody who's ctDNA negative because you can see the benefit of chemo in that subset is small. However, this is not yet ready from a de-escalation standpoint. But again, highlights that you can use this in trials, and it's an integral marker, not just an exploratory marker. And one nice finding about this trial that that often came up a few years ago was being ctDNA positive was not necessarily like a black and white death sentence. That it is something that's dynamic. You can change the positivity to negativity, as shown here in this light blue curve. These were patients who were ctDNA positive who turned negative on the adjuvant mop-up chemo, and their risk was as good as somebody who was negative to begin with. Not surprisingly, somebody who was positive or turned positive during adjuvant chemo and the subsequent testing, these patients did not do well. This was an analysis on over 1,000 patients in a real world setting using a tumor informed assay. And again, brings up the not only the feasibility, but the question of it's not just one of the best prognostic markers right now, but it's a predictive marker and more so reflects persistence of disease, and also would help identifying patients who are at high risk for recurrence and maybe who would benefit from adjuvant chemotherapy. More to come, and I would again put a plug for enrolling in some of the ongoing trials that are open in numerous places across the country through Alliance and many of these other cooperative groups. Um, Often the discussion puts a good segue into this landmark publication. Again, this was in New England Journal. This was an oral presentation at ASCO from Dr. T and our colleagues in Australia. Till this presentation came out and this publication the same day in the New England Journal, there was always that question that all the data that we talked about so far, these are retrospective studies, registries, real world, it's not a randomized trial. Well, now you have a randomized trial. This is an effort from the group in Australia looking at stage 2 colon cancer patients. And they did a randomized trial in which half the patients got the standard management and the other one got it DNA guided management. And as shown in this Kaplan-Meier curve, it achieved similar outcomes, meaning that you did not compromise the progression-free survival, recurrence-free survival in patients who got chemo based on the results of the ctDNA testing as opposed to clinical judgment or clinical care. I think the study probably needs more attention and probably should have gotten more impact. But I wanted to kind of highlight how this compares to the data we had in the past. It's important to remind ourselves that people whose ctDNA results are positive, that specific Kaplan-Meier curve goes down to 0% after a few years, meaning that pretty much everybody virtually recurs if you don't do something about it. So we're comparing, the results between ctDNA positive and ctDNA negative, and maybe that difference doesn't seem big, but if you compare it to all the historic studies where ctDNA positive patients did not get chemotherapy, that number that's at 86% several years out is a zero. So this is a huge improvement and shows that it is something that you can predictive act upon.
So you kind of very cautiously position this as something that should be considered in terms of clinical trial participation. But I'm seeing people doing it, investigators and docs in practice all the time. They're getting it paid for and they're using it. Are you not using it outside of trial yourself?
So yes and no. So like this particular situation, for example, a stage 2 patient where you weren't planning on giving chemo and the results comes back positive, I think the positive result is easy to act on. And as shown here in this next slide as well, there are several landmark registries and big publications where if you don't act on a ctDNA positive results, doesn't matter if it was stage 1, stage 2, stage 3, virtually all those patients have a recurrence. The publication by Dr. T et al. Shows that that bar is, as you can see in this arrow, is cancer-free, at a good 86+%. So people don't realize that this is something that's truly a great finding. And I remember asking the question to Dr. T as one of the discussants at the meeting at ASCO, that if you had a patient tomorrow with stage 2 colon cancer, would you use ctDNA? And her answer was yes. And I do agree and on that approach. For the stage 3, I think the key finding where the field is right now to understand is what a negative results mean. Because a negative result, I caution patients before even the results coming back, that a negative result means two things. One is best case scenario, you're cured. Or the second possibility is that we're looking for a needle in the haystack, and maybe the best of tests didn't find that needle, or in the immediate post-operative phase, there's a bigger haystack from the background noise of healing. So we just have to be cautious about not over-interpreting a negative result, equating that to cure, equating that to getting no chemo. If the plan is to give chemo, especially in a stage 3 or a high risk stage 2, you can use it for monitoring, surveillance. There is data about it picking up cancer months before the scan picks it up. So yes, we are using it in the clinic, but with the cautious interpretation of what our negative results mean. And then I would say we're lucky to have many trials, both for stage 2, stage 3. And I think right now with some of these trials running through many cooperative groups, I would say in the United States, we do have a trial to offer as part of our clinical care by using these routine assays.
All right, please continue.
And again, to highlight the key conclusion from Dr. T et al., they reduced adjuvant chemotherapy use. So the number of individuals who got chemotherapy in the ctDNA arm was half as many as opposed to the clinical judgment. So you got and achieved a similar recurrence-free survival with only half as many getting chemo. And chemotherapy comes with its own baggage, neuropathy, other issues. If somebody does not need chemo, the first statement actually in the NCCN guidelines for stage 2 is a frank discussion about the low benefit or the low risk of recurrence, because the most important thing to cure them is surgery, which has been done. So there is concern that we are over treating, and the trials right now, the Circulate US, which is actively enrolling, this is important to highlight that it at least justifies if you still had reservations about using ctDNA in the clinic, with all this data, you should at least not have reservations about putting those patients on ctDNA directed trials where decisions are being made in a controlled fashion under a trial setting. And then, again, to your earlier question, in the real world utility, while I think there is still some debate, I would say I've heard more experts agree that if you weren't planning on giving somebody with stage 2 colon cancer and their assay is positive, this is not a prognostic indicator. This means there is persistence of disease. You should act on it. And the data from Dr. T et al. Supports that you can change the recurrence-free survival from 0% in a few years to almost 86% disease-free. The next publication is more of a consensus statement that was published in JCO from the colorectal cancer expert panel. And I'm just going to highlight the key summaries, but they tried to look at 7 key practice questions and come to a consensus to help day-to-day questions that come up on every week on tumor board on a patient that is in front of you. So what were these questions? So the first question they were asked was the utility of doublet versus triplet chemo, FOLFOX versus FOLFOXIRI, modified FOLFIRINOX in patients with unresectable colorectal cancer. In short, the answer here is, depending on the individual patient, you can use triplet, you can use doublet. I would say triplets are coming back in fashion, and also the doses that we are using of the irinotecan and the 5-FU with modified FOLFIRINOX or FOLFOXIRI are not the same as they used to be. So patients are able to tolerate it, and where possible, there is data suggesting that there is probably an overall survival benefit, better response rate with the utility of triplet. So in the right patient, I would use a triplet, and this is what the consensus statement also said. Goes without saying, in the mismatch repair deficient MSI high colorectal cancer, which is about 4 to 5% in the metastatic setting, immunotherapy in the form of pembrolizumab is FDA approved. There was also a question regarding the utility of that in just MSS TMB high. I think that's where the TMB more than 10 is not as good of a cutoff for patients with GI malignancies as well as colorectal cancer. So caution there, unless it's a crazy high hypermutated, polymutated MSS colorectal cancer. We see a few a year. These are present. So outside of that indication, immunotherapy, it's wise to not use it unless it's in the context of a clinical trial where the patient might be getting something else in addition to a PD-1 blockade. The third and the next few questions were around the RAS, RAF, wild type colorectal cancer. And I would say last year, 2022, was kind of the year for the advances and more research on this particular subset, with the advances for colorectal cancer coming in subsets. This particular subset we learned more about. And for the truly left-sided RAS-RAF wild type, and we have some landmark publications highlighted as well in the talk later, anti-GFR use alongside chemotherapy, whether it's panitumumab, cetuximab, is recommended and should be used, not for the right-sided, but in the first line, but definitely for the left-sided. We saw approval and the utility of encorafenib with anti-GFR cetuximab panitumumab through the Beacon study that was published a few years ago. It's now something that's available second line and beyond for patients with BRAF V600E mutant colorectal cancer. So one chemo-free option in the second line or beyond that's available. It goes without saying that every single patient with metastatic colorectal cancer should get comprehensive panel-based, next-generation sequencing-based testing at diagnosis, so you know who are these subsets who are MSI high, who are these subsets that are BRAF mutant, who are these subsets that are RAS-RAF wild type, so you could be more precision medicine-based approach for these subset of patients. For the ones with peritoneal metastases, the PRODIGE study looking at the benefit of cytoreductive surgery with or without HIPEC. While HIPEC didn't offer additional survival benefit, cytoreductive surgery led to a median overall survival of upwards of 40 plus months. So in the folks who have peritoneal only metastases, this is something that's recommended. For the ones where you can't resect liver metastases, the guideline also looked at the question of can you use SBRT and this or the selective internal radiation therapy or Y90 radioembolization. This was recommended for the ones who are unresectable. More so, favorable opinions regarding SBRT. For the CERT or Y90, the statement or the consensus was more so that it's not recommended for everybody. Again, there's no such thing as uh, not for anybody. So in the right context, it shouldn't be just routinely done. Some caution was advised because of the collateral damage that you can have from these therapies. And then for the ones who are oligo, from the Greek word few, metastatic liver metastases, you could do perioperative chemo, you could take them for surgery alone. Again, these were things that were discussed in more detail. I just wanted to highlight and summarize the 7 key takeaways or questions that come up often that are available in this consensus guideline statement.
Going back to that first one, doublet versus triplet, I've heard that discussed as it relates to BRAF patients, but what other situations do you think about triplets?
I would say the right-sided tumors that in general you don't have the option of adding EGFR. There is a rise of colon rectal cancer in young individuals. Individuals in their 20s, 30s, and 40s are getting diagnosed with colorectal cancer. Often because they get diagnosed because it's symptomatic, it's often metastatic at the time of presentation. The question of conversion therapy often comes up. Somebody is not resectable today, but if I can convert them or shrink by X%, or if I can shave off the tumor from the blood vessel that my surgeon could do surgery for, I would say, in summary, there are a lot more situations. Obviously, it goes without saying it has to be somebody with a good performance status and preserved organ function. But it is not the traditional FOLFIRINOX dosing with the bolus 5-FU and the irinotecan at 180 milligram per meter square. When we are using these modified regimens with no bolus and the 5-FU infusion at 2400 in the US population, the irinotecan capped at 150, and now there's also suggestion about using pharmacogenomics for DPYD and UGT1A1 based dosing. These are tolerable and doable and feasible regimens that I would say are being used more often than they were a few years ago.
Please continue.
So going back to the segue of the anti-GFR or the subset who are RAS-RAF wild type, over the years, this has been a story of precision medicine and evolution. We knew that from almost 10 years ago that somebody who had a KRAS mutation, maybe they didn't derive benefit. Then we found out maybe the BRAF patients also don't derive benefit. Then the whole sidedness question came up. So we've gotten better at selecting patients for anti-GFR in the first line. And we have all these exploratory retrospective analyses that show that there is probably a survival benefit. In some studies, I'll show you some data, it's upwards of almost a year, but every single time this question comes up, it's still a debate question. I personally don't think it's a debate question anymore, but it's still a question: do I use anti-GFR or anti-VEGF first line? Well, now you have a randomized controlled trial, the so-called paradigm study, where they showed in a randomized trial fashion, this was plenary at ASCO, you can see the hazard ratio, you can see the OS difference between the left-sided RAS-RAF wild-type tissue patients who got anti-GFR with doublet chemo versus anti-VEGF. That this, for the first time, showed that it's not just the response rate which is higher, as you can see, almost a 15% difference there, but more so, this leads to a better overall survival. Some of that could also be because you can see you have a better response rate. Maybe you'll have a better shrinkage of tumor and cancer that leads to the benefit. Um, Regardless, I think this kind of set the stage for this being as a first line preferred option. And there's an uptake of this more so in the community now that this got presented. And my conclusion or takeaway here is I've summarized here in this table an NCDB analysis, the landmark CalGB 80405 study, the PEAK study, the FIRE3 study, now the paradigm study. If you truly look at the subset that should get an anti-GFR, which is your left-sided, your RAS, your BRAF wild type, and I'll throw in HER2 there as well, then this is OS. At the end of the day, we were looking for overall survival. It's not just a meager few months. You can clearly see a consistent pattern and trend. And sometimes in the first line setting, you may or may not have the results of the tissue sequencing back. There is a potential utility for liquid biopsies as well. It's now in the NCCN guidelines that you could use it for the rapid turnaround as quickly as within 6-7 days. You already know who is your MSS RAS-RAF wild-type patient who you could use anti-EGFR in, and that could equate to the better overall survival shown now in a randomized trial fashion and backed up by multiple analyses as shown here in this table. I also wanted to highlight this other publication that kind of builds upon this further and also highlights why liquid biopsies might be important. So this is the same study, the paradigm study. This was presented at ASCO, and then 6 months later at ASCO GI, the same group looked at liquid biopsy ctDNA analysis of the same subset of patients who got the anti-IGFR and anti-VEGF that I showed you on the previous slide. And what's intriguing is, you can see a bunch of KRAS mutant, BRAF mutant, as well as other mutations in the MAP kinase pathway that are resistance mechanisms, and people that you may not consider giving anti-IGFR to were in the treatment population. Now, what happens if you further hyper select these patients? That's what they called it in their paper, and then look at the data. So in the hyper selected patients, again, I wouldn't necessarily call it hyper selection because these are patients who shouldn't be getting anti-GFR anyways in our hands. But what happened? What you did, if you did that, that benefit of the 34 to 37 months goes up to 42 to 36 months. Again, going back to summarizing the previous data, you know, look at the numbers. If you just select the right patient for anti-GFR therapy, that survival number starts going upwards of 40 plus months consistently across studies, and then is in the low 30s for the ones who are not selected. So some people question the rash part. Well, if you're not going to use anti-EGFR in the first line, you're going to use it in the second line. So the fact that you won't get the rash first line, if it, you have to have a frank discussion with the patient why you are not going to consider anti-GFR, in my opinion, when you have, a 7 month plus OS difference, and in the real world, that difference is even higher. And again, reiterating the role of liquid biopsies as shown here in the analysis done by the Japanese colleagues. And then building upon the story even further on the anti-GFR part, the group from the Gono look at the question of, do you really need the triplet chemo if you were using anti-GFR as your backbone? If the anti-GFR is the key in the therapy selection, maybe you could spare the extra toxicity of the extra chemo. And that's exactly what this presentation at ASCO, and now it's in the JCO as well, the full paper. And they did not find a difference between doublet versus triplet chemo in the folks who were getting anti-GFR. So it actually, again, builds upon the anti-GFR selection even more, that you could achieve the same outcomes with less chemo, and you could reserve the other chemo for later line use. And that also might be the reason why you could get better overall survival, because you'll have more options. So in terms of choosing which patients for triplet, you could potentially spare the triplet toxicity of chemo in the ones who you are choosing an anti-GFR as a biologic. So this was a good takeaway from this particular study, where you can consider doublet as your backbone if you were choosing anti-GFR as your regimen. If the patient is not a candidate for anti-GFR because of KRAS mutation, BRAF mutation, maybe in those scenarios, if you're using anti-VEGF, if they have a good performance status, maybe you could use triplet in that scenario. So it's further refining the first line choices with all the data that came out in 2022. And then in the subsequent line therapy, if you're using anti-GFR in the first line or later line, we know from elegant work done by many European colleagues and also colleagues at MD Anderson, looking at some of the half-life of these clones, these resistance mechanisms that develop to anti-GFR, well, you could potentially lose them over time. So the tumors are not completely resistant or permanently resistant to a target therapy. Three trials and that all serendipitously start with a C, the Cave, the Cricket, and the Chronos. They looked at this question of rechallenge, which is an option for somebody who might have had initial response and then later progression. And again, this is one more real world utility of an NGS based ctDNA assay, or an assay that at least looks at all the mutations in the MAP kinase pathway. Um, the key takeaway is that if you were liquid mutant, that if you had resistant clones in your liquid biopsy, you derive pretty much minimal versus zero benefit. All you're getting is the rash from EGFR, probably no benefit. But if you were liquid wild type, so not tissue RAS-TRAF wild type, but liquid wild type as well at the time of your EGFR rechallenge, and you can use it in the real world because you can get the results back within 6 to 7 days, then you can spare the toxicity to those who don't need it. And the outcome of cave and cricket studies, this publication looked at pool data analysis. You're achieving a PFS of over 4 months and an OS benefit in refractory later line setting of upwards of 17 months. And the Chronos study, uh, you know, went one step even further. They did not even include patients who were liquid mutant. They clearly believe that those patients should be spared the toxicity. It'd probably be unethical to give them anti-GFR therapy if you clearly know that they have resistant clones. And showed here in this waterfall plot, as you can see, the response rate and the benefit in the ones who were anti-GFR candidates. And shown here in this illustration is simplistically what happens to a patient's tumor on target therapy, that you get a response. Then over a period of time, you lose the response because there are probably new resistant clones or a resistant clone that was already there, that but then has the ability to propagate. If you do a non-targeted therapy holiday, you can potentially allow for resensitization for quote unquote EGFR rechallenge or recycling or resensitization of same target therapy, which I would say is also something that can be done in the real world setting. As the authors of this particular publication called it zero mutation ctDNA triage, meaning that before you consider a person for anti-GFR therapy, just do a liquid biopsy to make sure they don't have any mutations that would make anti-GFR a failed exercise. You could argue, while the benefit is not tremendous, you can at least spare the toxicity to the patients who don't need it. Moving on, in the quote unquote salvage or refractory line, or beyond the traditional FOLFOX, FOLFIRI, FOLFOXIRI with the traditional biologics, what are the options and what are we learning about the drugs that are available in that setting? We have regorafenib, and then we also have the antimetabolite TAS102 or FTD available. What are we learning about these drugs? This particular ESMO presentation builds on the REDO study from Dr. Saab and colleagues, looking at the dosing of TKI. It's one thing that we're consistently learning, that less is more. So instead of the traditional 160 milligram dosing of regorafenib, they started at the 80 milligram dose, and also preemptive clobetasol use. The hand-foot syndrome is something that we see with TKI. So rather than reactive prescribing later when it's worse, starting off with preemptive prescription for that. It This was a network meta-analysis which showed that compared to best supportive care or the higher dose of the TKI or some of the other drugs in trials with fruquintinib, which is an anti-VEGF that we'll talk about later, that the benefit, as you can see, was almost an OS of 9.8 months. And going back to the original REDO study shown here in this illustration, more patients were able to stay on the therapy and didn't have to come off of toxicity if you did a 80 milligram starting dose with weekly escalation and preemptive versus reactive treatment for the clobetasol. And if your patient can tolerate treatment better, their quality of life is better, and they're going to stay on the drug better, and that downstream leads to a better progression-free survival and overall survival. The outcomes of patients with colorectal cancer has been a continuum of care. It hasn't been one wonder drug. It's just the fact that we have all these options, one after the other, that can be used and reused, that has allowed for the survival to go up from a few months, a decade ago, to upwards of several years now. So it's important to recognize and know about all these options at the right time. And then along the same lines, in the salvage or refractory setting, this randomized control trial that was published that was presented at ASCO GI is also a new standard of care. The so-called Sunlight study looked at the question of the addition of bevacizumab to the TAS-102 or the FTD TPI antimetabolite that's FDA approved already. This looked at the question of the addition of anti-VEGF, which is the same question of bevacizumab beyond progression that we have been doing with traditional IV chemotherapy. This looked at the continued use of bevacizumab even in the later line setting. This was a positive clinical trial. It met its endpoints. You can see the uh, overall survival as well as the progression-free survival were meaningful. Sometimes uh, our colleagues would argue that the PFS for some of these drugs is almost the next scan. Before you even get the next scan, somebody's progressing. But here you can see that there is a meaningful improvement in that endpoint. And what was also remarkable was that the benefit was preserved across subsets and across the patient population, whether it was your patient who had bevacizumab in the past, whether it was your KRAS mutant, whether it was a patient with liver metastases, without liver metastases, the benefit was preserved across all subsets as shown here in this forest plot. Um, it's important. I like the idea that all these trials are now also looking at quality of life variables and global health status variables, and uh, it's nice it's being reported at the same time rather than ad hoc analysis years later. Not surprisingly, this regimen also delayed the time to deterioration of the global health status. So it's not just the tumor that slowed down. This was not coming at the cost of compromising the quality of life of the individual, which is important as we talk about these patients being on therapy for years. So the key conclusion or key takeaways I often kind of talk about these tools in our toolbox for our patients with metastatic colorectal cancer. Now we have the option of the addition of anti-VEGF to this anti-metabolite that's already FDA approved. I would say this is not new. This was already in the NCCN guidelines over a year ago when the initial Lancet Oncology publication came out. I think this randomized trial further brought this to the attention of the broader global community and kind of corroborated the already approved NCCN guideline recommendation that this is an option. I would say it's important that this is not something that you would be doing or should be doing when you're. I've heard this being brought up when hospice is pretty much the only option left. That's not necessarily true. This is, in my opinion, a third line option. Or if you were doing, triplet chemotherapy upfront and maintenance, this is technically your second line option post progression on maintenance as well, rather than rechallenging oxaliplatin, more cumulative neuropathy. You could spare those options for later use. So this randomized trial makes it an option. This sunlight regimen in second line post progression or third line compared to some of the other drugs, preferentially in many books. And building upon the data further, um, this real world registry phase 3b study looked at almost 1,000 individuals who got the trifluridine tipiracil, the TAS-102, the drug we just talked about with anti-VEGF. Here they looked at other variables of what's actually happening in the real world. Sometimes the real world does not reflect the trial data. In this elegant analysis, I found it very interesting and intriguing that um, the longer you could stay on the drug, you were of course achieving ongoing control and better overall survival. But this was not necessarily coming at a cost of compromising quality of life. Like this was preserving it, leading to efficacy without the delayed, as you can see, patients without ECOG performance deterioration. So most of the times there are cumulative toxicities of certain drugs and regimens. The question of efficacy is brought up with trifluridine and tipiracil. I often tell my patients that I would say at least safety is something that and tolerability and quality of life is meaningful concern, and often if done earlier on, as you can see here, it's not something that patients are on for just a couple of cycles. Some patients can be on it for a long time, and we have to be careful when we interpret some of these median progression-free survivals or all survival. These are medians, not averages. There are definitely patients who derive minimal benefit, but there are also patients who derive a long benefit for a long period of time without compromising their quality of life. And now with the addition of bevacizumab, this is even more pronounced. One small practical observation that serendipitously we had reported back in 2016 was the observation that if you do get neutropenia or low white cells, again, this is different from neutropenic fever. Just the low white cells is more of a nuisance, but it's actually a good prognostic factor, both for progression-free survival as well as overall survival. This was corroborated in the randomized trial as well as in this 1,000 patient registry. So begs the question of, rather than decreasing the dose or delaying it, it's not unreasonable. I know the question of growth factor support sometimes in palliative setting is questioned, but if that is something that is a surrogate of good prognosis and maybe a predictive marker of how much drug gets into the system, maybe something to consider, not as an adverse issue. We are not necessarily dosing to neutropenia as in some of the Gyne-onc regimens, but rather than decreasing the dose, as long as you're not having fever or other issues, this is something that you could work with the patient in terms of what is the best strategy to keep the dose intensity going. And then the other randomized trial that hopefully would also be another option soon in the toolbox is this Fresco 2 study, which is built on the Fresco 1 randomized trial, looking at this oral VEGF agent called fruquintinib. This showed, again, met its endpoint. You can see the differences in the survival key endpoint that was achieved versus placebo versus best supportive care. And the waterfall plots also show in the side effect profile is nothing that we're not familiar with as GI oncologists. This is an anti-VEGF agent, so you're dealing with the same issues as you would be with the previously approved anti-VEGF agents. So not surprisingly, with hypertension and some of the other side effects that are well known and things that we're very familiar in how to manage them. The benefit also was also preserved in previously patients exposed to anti-VEGF. Anti-VEGF is obviously focusing on the tumor microenvironment, so it's not surprising with the data from the sunlight, with the data with bevacizumab beyond progression, and now this continued benefit with an anti-VEGF agent, that this is still providing benefit in our patients with metastatic colorectal cancer. Again, not necessarily a home run, but I would say this is something that probably will get another approval as another agent and maybe has the convenience of being a pill as opposed to ongoing intravenous infusion, which we also found that in the setting of pandemic can be very relevant in terms of the visits to the hospital or the so-called time toxicity, the time that patients spend in getting their treatments at all these cancer facilities. So again, I like to quote this slide, which is from 2008, which again shows that the advances for patients with colorectal cancer were not just from one wonder drug. It was all the advances that were happening in parallel, both in terms of systemic therapy options, advanced surgery, allied specialties. All of them add up to the overall survival advantage, with this option, as the authors quoted, potentially a new treatment option in refractory metastatic colorectal cancer.
I was going to ask you, do you see a fruquintinib as a sort of, I don't know, competitor, but similar to or replacing regorafenib?
So, it's a similar question that when even comes up even right now with regorafenib with TAS-102. I don't necessarily see them as competitors. I see them as drugs that the sequencing question may come up, but the mechanism of action is still different compared to regorafenib. So I don't think it will be taking its place, but the unanswered question would be, with these, three salvage regimens, there is a bias now towards using TAS-102 now that we have the data with Bev. That PFS in OS is unmatched unless somebody is not a candidate for anti-VEGF for some reason. But we don't know the correct answer yet, but I don't think it will replace the drug. It will be one more option in the toolbox.
And do you think it's better tolerated than regorafenib?
I would say, we'll have to see the real world experience. In the trial setting, the side effects that they're reporting, as shown here in this table, are very similar to what I would expect with any of the anti-VEGF agents. So there were no unexpected adverse events that we weren't familiar with. As you can see, most of them were, minor grade AEs, with hypertension being the most prominent one, and a third, fatigue. But nothing that we are not used to. And the grade 3 plus events were only seen in about 10-13% with hypertension. All the other severe AVs were less than 5%. So nothing that we're not familiar with in terms of managing. So I think I don't expect that the toxicity part to be an issue here with this particular drug.
Okay, please continue.
And then, while advances have been coming in like these molecular subsets, we talked about the RAS-RAF wild type, we talked about the BRAF mutant, we talked about the MSI high. One interesting observation that is now backed up with several other studies, this one particular study of note being one of the first ones, looked at the question of benefit of immunotherapy-based regimens in patients with microsatellite stable mismatch repair proficient colorectal cancer. Now, as a reminder, the immunotherapy, while it's standard of care, it's the only situation where I've heard the word cure being used with MSI high colorectal cancer, even in stage 4 settings. These patients, when they do respond, it's a gift that keeps giving. This is in sharp contrast to patients who are mismatch repair proficient colorectal cancer, microsatellite stable colorectal cancer, where pretty much the responses are 0%. And patients should not be getting immunotherapy if they are mismatch repair proficient or MSS. And here you're seeing an overall response rate of 42% and a waterfall plot that looks pretty decent. But what was very intriguing, or more intriguing, was the observation that that this is mainly being achieved in the subset of patients who do not have active liver metastases at the time. Shown here in the light blue are patients who had active liver metastases. Pretty much, as you can see, every single patient had progression. Now, it's not like you can't have had liver metastases. Just at the time of the study, either they had to be resected or ablated. And there's another study that's ongoing right now that's allowing patients with no history of liver metastases, or if you had resected ablated metastases without recurrence for almost 6 months, this so-called BOT-BAL regimen. The BOT is the botensilimab, which is a novel CTLA-4 drug that I'll show you the picture in more details in the next slide. And the BAL is the balstilimab, which is an anti-PD-1, just like any other anti-PD-1 that's out there. This was presented by Dr. Al-Khawri and colleagues at ESMO World GI, and there was some more update at ASCO GI. And you know, it is a new drug. This so-called bot, according to the manufacturers, it's an FC enhanced CTLA-4 inhibitor. It probably has more C cell priming, more expansion, more memory. It also takes away the bad Tregs, probably decreases the complement-mediated toxicity. So maybe it's a better drug. Maybe that's what's causing the response. Or is it the microenvironment of the lung only, or non-liver metastases patient? Is that driving the show here? We'll know more. And there was also data just a few weeks ago by Dr. Marwan Faqih and colleagues that looked at regorafenib with ipi-nivo, the so-called RIN regimen. And again, overall, the results were disappointing in this macrosatellite stable colorectal cancer, and also the few years ago, the Rego-Nivo combination that was very fascinating in the Japanese cohort, but pretty much in the US cohort was very disappointing. The subset analysis of the patients who had lung-only metastases or non-liver metastases show similar patterns. So while not discounting this as a new drug, I do think the new drug is also building on the observation that patients with this subset of the setting where you have a non-liver metastasis situation, it's more conducive to possibly immune-based regimens. So whether it's the novelty of the drug or the lung-only metastases, it is the first time we're seeing any activity of an immunotherapy based regimen. So it's very much of value and intriguing and heartening to see waterfall plots like this. Again, the work is not done complete, but for the first time, we're seeing a signal here. And like I said, there are right now ongoing clinical trials that are now selecting the patients who with non-liver metastases for some of these regimens. I wish there were treatments and options that would be for all colorectal cancer patients, but I think this particular work highlights that there are some subsets where it's more so molecular selection going on into selecting the right candidate for, let's say, anti-EGFR therapy or the MSI high for immunotherapy. Here, I think it's not uncommon. It is a frequent occurrence. Even today, I had a few patients who only have lung-only metastases who may benefit from such a strategy. So, and also, I think, on the flip side, patients who, for example, have widespread liver metastases, they could be spared the unnecessary exposure to a regimen that may or may not work for them. So, in summary, I think the advances in the last year or two, for colorectal cancer has taught us even more the value of identifying the subsets who may benefit more from a precision medicine based approach, whether it's the NGS based testing, whether it's the liquid biopsy, whether it's the sidedness, and more so now this with this BOT-BAL regimen, the location of the metastases in the refractory line setting.
I'm trying to even come up with any kind of hypothesis that would explain why it doesn't respond in the liver and does in the lung. Anything that you can come up with, or
You
you've
know,
heard people come up with?
there's definitely a lot of work being done here, and actually, it's not just colorectal cancer. We've seen this over the years with non-small cell lung cancer, melanoma. We understand that it's not just the location that the liver is the anatomic site of spread. The liver itself is an immunosuppressed environment. There is a lot of bad immune cells from a tumor standpoint, like in terms of high proportion of Tregs. There is a reason why cancers like going to the liver, because they can then simplistically hide under the radar of the immune cell surveillance. So patients who have metastases to the liver, often systemic therapy with immunotherapy hide under the radar. Our transplant colleagues knew about this from a while ago. From what I understand, the amount of immune suppression that's required for a liver transplant is less than some of the other organs. There's also some work published just a few months ago that argues that the liver might not just be a site of metastases, but simplistically might be a command center. There's crosstalk going on between these metastases. So, thinking out loud, could you do something different to the liver location, whether it's some form of surgery or radiation, or we talked about the ASCO guideline statement recommending, SBRT or Y90 in the select cases where it's not resectable. Could you view that as a separate battle that you could address separately and still allow for systemic therapy to be an option for the remainder of the body? I think it's a question that's being asked in some of these upcoming trials, and maybe that's the new direction, understanding these as separate situations.